A modern dental practice operates on a complex framework of strict regulatory risk controls that extend far beyond routine surface cleaning. Under the Dental Board of Australia, infection prevention and control is a non-delegable legal duty. Liability for these standards rests entirely with the registered practitioner. Structured risk management. To construct this system, we must deconstruct three specific vectors. The first is the modern pathway for managing blood-borne viruses. The second vector covers the mechanical and chemical rules of point-of-care bioburden control. The third vector focuses on the material science required for correct PPE selection. Any deviation from these specific protocols constitutes a direct breach of the AHPRA Code of Conduct, placing your clinical license at risk. A blood-borne virus diagnosis no longer marks the automatic end of a surgical dental career. This relies on the definition of an exposure-prone procedure, or EPP. These are scenarios where the practitioner's fingertips are out of sight for a significant part of the procedure. Working blindly inside the oral cavity introduces the risk of the practitioner's blood contaminating open tissue following an injury from sharp instruments or bone spicules. This chart summarizes the mathematical risk of transmission between untreated individuals. It compares the transmission percentages for hepatitis B, hepatitis C, and HIV. The data discrepancy shows that healthcare workers are significantly more likely to acquire an infection from an infected patient than the reverse. Because of this, the CDNA 2019 criteria moved the clinical standard toward viral load suppression. Infected healthcare workers can legally perform exposure-prone procedures if they are actively complying with prescribed antiviral therapy. This requires the practitioner to maintain a viral load suppressed below 200 international units per milliliter for hepatitis B or HIV. Maintaining this EPP-approved status requires adherence to a strict testing and documentation schedule. Practitioners performing EPPs must undergo baseline testing for these antibodies every 3 years. Additionally, any blood and body fluid exposure requires immediate baseline testing of the injured staff member. Viral load suppression and rigorous testing records now define the legal standard for surgical practitioners. Beyond systemic risks, we must manage the routine environmental risks governed by the National Hand Hygiene Initiative. For visibly clean hands, an alcohol-based hand rub listed on the ARTG is the clinical preference over soap and water. Alcohol-based rubs preserve essential skin lipids, whereas traditional detergents strip them away. Frequent use of liquid soap and abrasive paper towels often leads to occupational irritant dermatitis. These skin microfissures serve as deep microscopic reservoirs that trap and protect harmful pathogenic biofilms from standard chemical antisepsis. The correct operational metric for alcohol rubs is to dispense enough product to require 20 to 30 seconds of active friction to dry. Traditional hand washing remains a requirement only during specific instances, such as visible soiling or potential spore exposure. To maintain these hygiene standards, the bare below the elbows rule acts as a critical mechanical control against fomite transmission. This prohibits the wearing of watches, fitness trackers, and long sleeves during direct patient care. Even small pieces of jewelry can physically compromise the tight seal and the structural integrity of thin, disposable medical gloves during procedures. Furthermore, the skin beneath wings harbors heavily colonized populations of gram-negative bacteria that resist chemical cleaning. To prevent glove punctures, fingernails must be short, natural, and entirely free of extenders or polish. Mechanical traps on the practitioner's arms will harbor bacterial biofilm and compromise chemical antisepsis. Effective barrier protection requires treating gloves as specific engineered systems matched to clinical use cases. This magnifying view highlights the acceptable quality level, or AQL, determining the definitive standard for batch integrity. A lower AQL score indicates significantly fewer microscopic pinprick defects right out of the box. During a procedure, the thumb and forefinger regions experience severe shear stress that can turn these microdefects into active leaks. The glove material must also provide chemical resilience against the hazardous substances used in daily practice. Materials like natural rubber latex will quickly melt and degrade when they are exposed to the common organic solvents and methacrylate used in bonding. Additionally, the chemical preservatives in latex gloves can completely inhibit the setting of elastomeric impression materials. Nitrile gloves offer operationally superior tear resistance and robust protection against standard dental bonding agents. It is essential to distinguish the material requirements of standard precautions from the sterile, batch-controlled requirements of surgical aseptic technique. Selecting an incorrect material compromises the clinical barrier system before a procedure even begins. We can now review the entire compliant operatory framework. Under the 5th edition guidelines, clinical compliance is a verifiable and auditable system. The ADA's hierarchy of risk controls provides the final operational checklist for the modern practitioner. This starts with elimination, safely deferring non-urgent treatment for highly infectious patients. Engineering steps include utilizing high-volume evacuation and optimizing ventilation rates to physically remove aerosols. Finally, administrative controls provide the documentation required to prove legal compliance. You must maintain updated IPC manuals, logged continuing professional development, and recorded staff immunization statuses. Fulfilling your non-delegable duty of care requires managing infection control as a rigorously engineered, continuously documented clinical science.